Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. We're getting the system all set up, and then we will begin. Good afternoon, everyone. I'm sorry for our technical difficulties there. I want to welcome you to our MTM Summer Series on the topic of transitioning your providers, your clinical providers, to episodic care using effective evidence-based practices, including group therapy. My name is Valerie Westhead. I am a medical consultant for MTM Services. I work with a lot of teams around especially integration of medical and clinical services and a lot of the evidence-based practices that can be very helpful for individuals as they are trying to become more efficient and more effective in their services that they are delivering. Katherine, would you like to introduce yourself?
Sure. Hello, everyone. I am Katherine Schroder, and I'm a licensed mental health counselor, certified addiction professional, and I'm one of our process change consultants here at MTM Services. I have extensive experience with both leading clinicians and being a clinician, and also just helping to transition into this type of model. So I'm looking forward to having this conversation with everyone today.
So as a part of our learning series, we do record all of our presentations, and Katherine and I are releasing our slide deck to you as well. So in 2 to 3 days, you'll be able to find that on our MTM website. There are some links in this slide deck that we hope will be of benefit to you. As we are going through the presentation, please feel free to send any questions you might have either through the chat or the question button that's on the GoToMeeting. If you're having any issues in the background, you can certainly go ahead and reach out through the chat, and we'll be able to help you that way as well. So let's go ahead and get started. First couple of slides are really a little bit about MTM Services. If you've been to any of our webinars before, you know the things that we do. Here's the team that works together to help you with the things that you are interested in our support on. It's a pretty diverse team, and I find it very enjoyable to work with so many people with so many different experiences. So today's topic, our objectives are to help in the demonstration of medical necessity in clinical services. That is an essential element that, especially as we enter into value-based care, is going to be scrutinized even more in the next year or two. We're also going to talk a little bit about the effective stratification of clinical service delivery and how to utilize all staff at the top of their licensure. Understanding the effectiveness of evidence-based short-term therapy models, including the use of group therapy, and then strategies for overcoming clinician and client barriers to this new way of approaching care. Episodic care is different from a lot of standard practices, and we believe it can be of great benefit for you and your teams, and certainly for the clients that you serve. So, as I mentioned, we are all looking at the value proposition for behavioral health services in the future. There's always a dynamic tension between quality and cost. And quality really comes down to, is the client getting what they need when they are in need of services, and is it helping them to make the changes that they need to be live the life that they would like to live. So we always come back to, are the services quickly accessible? If you have large caseloads and a large no-show rate, your provider time, your clinicians are not being used to meet the needs of clients who are ready to access care. High quality services are efficient services, and making sure that we are providing services that are the most immediate and can be done in the shortest amount of time so that the client can really recognize the benefit that they are gaining from those services. We want to make sure that we are interconnected, that we are working as a collaborative team, whether that's with case management, clinical services, medical providers, peer supports, any of those kind of client-facing disciplines need to be working together so that the client feels and recognizes that they are receiving services from a team of providers who are working collaboratively. We want to make sure that we are demonstrating true measurable improvement in clinically relevant domains. And then we want to be prepared to work smarter and not harder to make sure that we are determining, hey, is CBT actually working for this individual, or would they benefit more from a different kind of approach? Where are they at in their readiness to change perspective? Are they ready to change one element, and that's what we'll focus on, rather than working on the entire picture that we can see is where all of their needs are? So it's really focusing on what does the client need right now to make a significant and measurable change in their life. We know that people change in certain specific ways. Everyone on this webinar could identify things that they would like to change, whether it is a psychological stress, something about a relationship, something about where they're at in their career. We all have things that we would like to change. But it really comes down to what are the benefits of change and the benefits of not changing. So thinking about how will we identify with a given individual where they are at in that why process. Are they interested in making things better and they see change is only going to improve things, which is a very positive kind of stimulus? Or are they in the place where not changing is only going to keep things in a bad space? So we want to make sure that we are working with clients and understanding what the impetus is for them as to why they want to change. And at the end of the day, what are the costs of change? Even if something is a very positive change, there is a cost for the individual. It's giving up something familiar. It may mean that some things will not be the same. It may be that they're giving up certain things, certain lifestyles, etc. But what they really want in their life is going to happen only if they're willing to take the cost into account and say, I'm willing to pay that price. How do we change? We like to see very short-term results. We like to see things get better quicker. So we also have to understand change is about action. We can do a lot of talking about things, we can do a lot of thinking about things, but until we start to do action, then it's not going to make a big difference. So we have to help our clients understand, let's think about your big overarching goals, and let's talk about the shorter steps that it's going to take to get there. And what has to be changed or do you need to do that will help you see a difference in the next week, the next 10 days, the next 2 weeks, because that is how you build up momentum for change. And looking at episodic approaches, you're looking at a shorter term focus so that you can help your clients you're working with see that things can get better one step at a time. So you want to make sure that you have activities that are scheduled that are a part of your plan and not just focus on a given, say, a mood state. People who are depressed are not going to become less depressed overnight. What will help them to get less depressed is if they are becoming more activated in their life, and then their mood will slowly improve. We understand that. We need to help them understand that when we talk about doing specific activities, that's what we're referring to. Helping them to see that they are involved in a positive and rewarding experience is going to be a natural reinforcer. Obviously, we have to spend a lot of time looking at the ambivalence and the avoidance behaviors, and we're all familiar with that from our own personal experience and from working with clients over time. When you are working in a more short-term approach, it is much easier to kind of to work away at those ambivalences and to see the short wins and be able to help people come to a place where they can become good problem solvers and to realize small changes can make a huge difference and they will start to build on each other. The question is, as I said before, readiness to change. We have to make sure that our treatment selection truly matches where the client is at. What is it that they are really thinking is something that they could change, and they see that change leading to the positive outcome they're looking for? So we've learned all about this from motivational enhancement and motivational interviewing, but it's important to keep that in mind at all times when you are working with clients. You want to make sure that they understand that you are working to help them make changes that are going to ultimately lead to an improvement in their overall functioning. And if they're really in the contemplation or preparedness stage, what you're going to do is going to be very different than if they're in action or maintenance. So we want to make sure that we are cognizant of where our clients are with regards to all of these things, and to realize that it changes from session to session. And being in an episodic mode, we are much more focused on what's happening in the here and now. So we want to really be cognizant of what are the stages of change. At the end of the day, we ultimately have to prove that what we are doing is medically necessary. We need to make sure that we have identified with an individual either what their list of problems are, what their diagnoses are, and how those things are impacting their ability to function. If they are not impacting someone's ability to function, an insurer or a funder might say, I don't see the necessity for it. So we want to make sure that we are very clear, and we help our clients to be very clear on those things very specifically. We want to, again, create treatment plans that are person-centered and goal-directed, because we're going to keep those goals at the forefront, especially in an episodic care approach. We're going to, hopefully, as an organization, develop some good care pathways so that we know all the services that should be provided, how they're going to intertwine with each other, and that we are going to use those services with fidelity to the model as we've created it. And at the end of the day, we want to be cost efficient without sacrificing any effectiveness or access to care. And that is one of the most important things that episodic care can do for you and for your clients, is that it makes your services available for more individuals, and it really captures for them the urgency of making changes in the areas that matter most to them. How do we do that? We do that by focusing on treat to target. We want to help the client to identify manageable goals and objectives that can be achieved in a finite period of time. We've all heard a lot in the last couple of years about SMART goals and SMART objectives. We need to make sure that we are looking at what are the short-term gains that would matter most to this individual, and make sure that they are specific, measurable, achievable. Someone can have some great goals and some really good ideas of what it would take, but they may not be able to achieve them. And I think probably for me, the most important one is timely. We want to make sure that there is a time frame in which these things are going to happen, because that gives us something to measure against, that gives us something to keep our focus on progress. We're going to select the effective care pathway. You know, that we can go in all kinds of different directions. I recently just drove into Chicago, and boy, was that a little bit harrowing, but it's a question of what is the right path to get me where I need to go. And then make sure that we truly are measuring the progress. In short-term episodic care, we do that at every encounter. We are always checking in. How has the things that we talked about made a difference for you? What has it helped? What has it not helped? Is there something else that has entered the picture that we need to think about? But we really want to keep our focus on, let's identify progress, let's measure it, let's make sure that we are working together in the same direction. When you do that, when you are treating to the target, when you have identified what the needs are, and you are working diligently on a path, you are developing for this client. They are able to feel hope, they are able to recognize their own resilience, and ultimately their own self-reliance. Let's be honest, we spend 55, 60 minutes in a therapy session, maybe a little less, and then they have the whole next week to 2 weeks that they have to take what we talked about, what we identified, and put it into action. So we really want them to understand we are here to support you, and you are capable of doing this. So we want to make sure that in order to get consistency, that we are keeping it as simple as possible from session to session, that we are very consistent in our approach, that we are always focused on, if we are not making progress, we've made some progress but not as much, that we are going to reevaluate every time we get together and kind of tweak things in the right direction. We want to make sure that we are monitoring, that they are aware of this, that they're doing this and providing their own self-care in between sessions, and that everyone that is working with an individual is following the exact same treatment plan, that we're all working together. We may have 5 different goals and there's multiple objectives under each of those goals, but we are all working to achieve the same outcomes. That helps the client to understand that we are a team and that it is that kind of effort that's going to lead to the improvement that they are looking for. So sometimes it comes down to, as I said, you got 5 goals, you got multiple objectives under each of them. Where do we start? Usually you start where the client has identified. This is what matters to me the most. And so we want to think about not what is a primary diagnosis, but what is the principal diagnosis. And the difference is, I may have someone who has a substance use problem and depression, and they're facing homelessness because they've lost their employment. So I need to be thinking about, with them, what should we focus on first? How do I get you the case management and other services that you need? Because we're going to focus on your understanding of your mood and maybe your substance use and how those interplay. Because we want you as the clinician to focus on where you are a unique team member and do the therapy that needs to get done, and look to have other folks with other expertise to be able to work on those things with the individual. Again, we all have the same goals, we've got overlapping objectives, but we have specific interventions. It's really important that we keep the focus on co-occurring competence. And we're not just talking about mental health and substance use. We're also talking about any primary care health issues that a person is dealing with. And yes, as a clinician, that may not enter into the picture quite as much, but if you're someone who has, for example, diabetes, and they have fluctuating comprehension because their blood sugars are running too high or too low, you want to have an understanding about that. You want to check in. Are they doing good self-care? Are they managing that well? If not, what's going on? Is it because they're so depressed that they just don't even care? Is it because they've continued to use alcohol, which is throwing it off? It's using everything you know about the client and treating them as a whole person. That's really important. We always have to be thinking about, what are the deficits? What is it why are we doing this? What are the goals? What are the things that they want to improve? And then always being aware social determinants of health will make a difference as well. Big believer in multidisciplinary team-based care. That's what we're talking about here today, and what your unique skill set brings to that table. And that is being able to do very intensive and evidence-based therapy using some of the models that Katherine's going to talk about in a moment. And then figuring out how to make sure what each team member is doing is fitting together, like getting way of doing this. Now, someone who comes in with multiple problems, that's not always so easy, but a lot of times our clients come in with very specific concerns. We want to start at the least intensive level, and we want to make sure that we are assessing regularly and frequently where they are at in achieving their goals. This is one of the best ways to customize what a client needs and to use all of your resources effectively. It is something that also will help the client to understand that they have a great deal of strengths, and that therefore, if you can work on a specific targeted area, those strengths that they have demonstrated in other areas of their life can be put to use as they are working on whatever the problem is that they are concerned about today, or whatever the challenge is that they're concerned about today. And there's a lot of research that really backs up this kind of approach, starting at the most basic level and then moving forward as a client shows that they maybe aren't going to be able to respond, or that they need more assistance with that, which with our population is often with their primary care physician or their primary care provider. Their primary care providers probably, if they're dealing with depression or anxiety, many of the common things that we see in our world, has already started some elements. And so our job is to be available for those that are outside of their scope of practice, and then to also consider once someone has stabilized to refer them back to the system of care that they are familiar with, that is their more routine way of dealing with whatever issues arise. So it's realizing that we may be at a community mental health center, but our teammates extend beyond our four walls. Our teammates involve everybody who's involved in helping an individual to address their concerns and become have their healthcare be wholly integrated. So when you are thinking about this, it's really thinking about, we all change at different paces. And even as we may be improving or changing in one area, other things will come up. So we want to make sure that in all of our work, whether as a clinician, as a physician, a medical provider, case manager, that we are doing routine check-ins to make sure nothing has changed, to make sure that we are informing our patients, their families, their support systems about what it is that we're managing, what we believe will be of benefit to them, what we're working on together, and what are some of the self-management skills that they can have. And again, this is where group comes into it, because self-management and learning from others is a great way of understanding how to help yourself. There's also a lot of technology out there. Finding out what technology they are using already is a good place to start. And if you believe there's some technological supports that would be of benefit to them, making sure that you're incorporating that into your conversations with them and into their treatment. Obviously, we're going to provide evidence-based counseling therapy, and Katherine is going to talk about that in a few minutes. We want to make sure that if medications are necessary, they are prescribed and clinically indicated. And as we make changes, we want to make sure that the client is reaching their targets, and that our efforts are all aligning and helping them to get there. So stratifying care is really what we do all day, every day, and it's about that teamwork that's going to make a difference. As we are really focused on treat to target, we all have to obviously row in the same direction, and that starts with the client. We want to be evaluating constantly, are we achieving weekly goals, session to session goals, and what are some of the things that we can use to help the client get to that place? We want to make sure that our mindset is to be solution focused, that we are helping the client to be solution focused, that we are using evidence-based service delivery, adjusting as things move forward, creating a plan that is flexible but consistent. We all know that sometimes we're doing our best when a client becomes a little resistant, and we want to make sure that we are helping them to understand the reason why we are doing things in a certain way, and that if they will stick with it, they will see the progress that they're looking for. And then as we think about an episodic approach to it, we are asking them to have a beginning, middle, and end to a particular encounter with your services, realizing that they should come back if something else comes up, or if they start to see that they're not able to do it consistently, or that things are drifting backwards. So we want to make it very clear we are not just doing an 8 to 10 to 12 week intervention and then that's it. It's more about, let's do that 8 to 12 weeks. We believe you'll achieve these particular goals, and let's see how you do for a while. So it's realizing that we're changing the paradigm because there's a lot of evidence behind it, and it is really the most empowering way to help clients achieve their goals. So I'm going to end my portion with that same readiness to change. Our changing is something that we don't necessarily always do all that easily either. These are the questions you should be asking yourself. Are you comfortable with time-limited therapy, with realizing we're going to be very concentrated with using 8 to 12 sessions? I use the analogy, that's a dosage. I'm not going to give someone more Cymbalta or Invega or any other medication than they should have. I'm going to evaluate when I might be ready to stop it. We don't get put on antibiotics indefinitely. What you are doing is providing something that should be titrated based on a client's need. And the best way to know what their need is to use measurement-based and client-centered goals. Katherine's going to go over some of the very common evidence-based modalities and group therapy. And sometimes we have to refresh ourselves on this as you think about moving into this direction. And maybe talk with colleagues who have been doing particular things longer than you have. Using your own resources, making sure that you are comfortable with doing this is going to go a long way for you being open to the idea of making this change. I think another thing that I always understood when I was early in my career, and way back then I actually did a lot of therapy. We were allowed to do it then. A no-show often didn't mean that they were disengaging from service because of something that I had done. Often it had to do, they had reached a point where they had achieved what they wanted to, and they didn't want to disappoint me and say, I think I'm finished now. I found that over and over and over again. It also can be that what we're doing isn't necessarily helping, and our being open to the idea of always checking in. Is this making the difference that you were hoping for? Do you see that this is helpful? If not, what isn't helpful about it, or what isn't that we aren't accomplishing with what we're doing now? It's keeping the focus on we are looking forward, we have a goal that we're trying to get to, and we want to make sure that what we are doing together is actually working. At the end of the day, it really is about, is what you are doing medically necessary? Is it making a difference? Is it a value add for the client? And is it cost effective? So I'm going to turn this over to Katherine, and she's going to do some conversation about different types of evidence-based practice.
Thank you, Dr. Westhead. Yeah, so we're going to chat a little bit about some of the many options that exist related to how you as a clinician, or if you supervise clinicians, things that we can be doing, as well as I just want to provide some resources that you will be able to access from the PDF that will be shared on the website within a couple of days. And then we're also just going to kind of finish out by talking about how do you deal with those difficult to transition clients and the issues that come up there. So there's three primary evidence-based practices that I really want to highlight a little bit, and hopefully you're already familiar with these as well. But first, talking about that solution-focused brief therapy, or SFBT. We all know solution-focused therapy, it focuses on exceptions. So at some point in this person's life, there's been a successful handling of a situation. How can we figure out what that was? How do we replicate it? I think many of us in our training as clinicians, we hear about the miracle question. It truly is a miracle question, right? We ask, what does it look like when you wake up and everything is exactly as you want it to be? How do we get there, essentially? And then, of course, critical, and this is really critical to all of your more solution-based or short-term treatment models, we're really focused on that future. We're focused on what's happening now, as opposed to getting into that psychodynamic, talking about childhood in any kind of extensive way. And the thing that I particularly really like about solution-focused therapy that I think kind of brings home for people, even when they've made sort of a minor change that they can really see and appreciate, is the fact that we can use a lot of scaling questions with solution focused. So we can talk about, on a scale of 1 to 10, how ready are you to make this change right now? Okay, you're a 5. So what do we need to do to move you to a 5.2 or a 5.5? We don't need to get all the way to a 10. We just need to figure out how you get to that next little step, and then we move from there. And maybe in, 30 days, we ask the question again, where are you now? Okay, well, we're at a 5.5. That's amazing. Think about that change that you've already made. So it helps bring that very black and white thinking that we often get into, and as humans, we do this all the time, where it's either we've failed or we've succeeded, and it breaks it down into those smaller successes so that they can really see and appreciate the change that they have made and hold on to that. So when it comes to fidelity with solution-focused brief therapy, we're really looking at maintaining that focus on the goal. So a lot of times, as clinicians, I have been there, I've seen it with my own teams. It can be kind of easy to start to let things drift. Maybe you're tired, you've had a lot of sessions. There was a really draining individual who came in just before this person, and this person's nice and easy. And so it can be very easy to kind of drift off of the goals a little bit, to kind of be led away from those areas. And so it's just important that we maintain that focus on the goal. We're staying very coping skill focused. And of course, with solution-focused therapy, we're really looking at positive and hopeful messaging. You'll notice at the bottom here, there is a link to a solution-focused training institute. This is a really excellent resource for you all. This is something you can access that has both some free resources, but also some actual trainings that you can do either as a solo clinician or for your team, and those are virtual. So I do highly encourage you to check those out if this is something you're interested in. Next slide, please. And of course, we're all familiar with cognitive behavioral therapy. The thing that I notice a lot and have noticed over the years and in my time working in behavioral healthcare is we are often asked, you know, what's your theoretical framework, or where are you coming from? What evidence-based practice are you using? And there's kind of a generic answer that we hear a lot, which is, oh, I'm cognitive behavioral, right? I do CBT. But what does that actually mean? And are we actually doing it in a way that really is towards fidelity, or are we kind of using the buzzword? With brief cognitive behavioral therapy, this is a very specific evidence-based tool that condenses your traditional sessions from that 12 to 20 into a very brief 4 to 8. So when you look at brief CBT, you're looking at those first few sessions being your active sessions, and then they go ahead and increase that length in between those sessions, and they're kind of considered booster sessions at that point. So this is highly, highly, highly focused. You'll see a lot of the common CBT types of techniques in this more brief model as well. So those of you familiar with CBT, you'll kind of remember the ABC technique, your antecedents, behaviors, and consequences. There's a lot of that as well, because you're coming back to that root cause, you're working towards solutions in that reactionary cycle. And of course, you're going to maintain fidelity by utilizing those principles and tools. On the bottom here, your link here that's going to be very helpful for you if this is something you are interested in, is going to be this guide that is specifically for therapists. This is completely free. It is over 100 pages. It's incredibly helpful. So I really strongly suggest that you use this. This is a great team learning activity that you could use, but it's also just a great manual for any therapist or clinician who's interested in utilizing brief cognitive behavioral therapy within your own work. Next slide, please. The final one I want to highlight before we talk about kind of dealing with those difficult to transition individuals and how we can work through that is kind of it's a little bit different from the other two's kind of focus, and that is your ACT therapy. So that's your acceptance and commitment therapy. What's really different about this is that this is getting into more of a broad set of philosophical ideas. It does draw from behavioral therapy techniques, but it also brings in some of that newer thinking related to mindfulness, related to radical acceptance. And just like our yogi picture here on the page, we're looking at alleviating psychological inflexibility. So again, we really get back to that kind of, hey, humans tend to think in black and white, right? And so we really look at, rather than trying to take all this time to completely eliminate existing coping skills, the coping skills that weren't working for us, the coping skills that maybe are holding us back, instead of taking a lot of time trying to remove, let's instead add these alternatives on. And that way it gives a little bit more option. You can reach into that toolbox for something different. And again, it's going to look more at some philosophy, right? Some ways of thinking about things that's a little bit different. The link that you're going to find here has a lot of great resources, and that is the Association for Contextual Behavioral Science. They have a whole nice section about ACT therapy, and again, strongly suggest if this is one that you're interested in, taking some time and really utilizing that link there. Go ahead and go to the next slide, please.
While I'm doing that, I'm going to let you know that a lot of psychiatric residencies actually teach their residents about the ACT model. So as you're thinking about how you might better connect with the medical staff that you work with, that might be a common thread that you could utilize. So it's just become, I think, a more common across the board kind of approach.
Mm-hmm. Right. And again, going back to, if you have the ability to collaborate, to integrate, to work across systems, if you can work with those psychiatric providers more than just, hey, I happen to know this person is engaging as well over here. I mean, just the ability to move that person forward is going to, expand tremendously. It makes it that much easier for you. So that's really great. So the bottom line, supervision, does not matter what level you are at as a clinician, how long you've been a clinician, really making sure you have that supervision is going to be key. And when we say fidelity bottom line, we're talking about fidelity to the episodic care model. If we are going to move from kind of no specific end date in sight kind of session mentalities, and we're going to bring it to this kind of idea of, again, you're treating to target, then we need to make sure that we're checking in with somebody else as well as just ourselves to ensure that we're sticking with this. So this means we have to be bringing challenging cases. You know, I know as a qualified clinical supervisor, as well as someone who went through, you know, the years of required supervision, that very often we're tired, right? We have tough work that we do. We have very hard work, and it can be very easy to just bring those kind of easier sessions. Maybe we're embarrassed about something that's happening in our more challenging cases, or we just don't have the energy to go through it. You know, if you are someone who provides supervision, really working to make sure that those individuals, your clinicians, are bringing their challenging cases. That's great to hear about successes, what's happening in those challenging cases. And if you're a clinician, to really challenge yourself to make sure you're bringing those as well. So if you're starting to notice a drift that is happening in your sessions, you're struggling with sticking with that kind of model, it's very important that that gets discussed. And supervisors absolutely need to make sure that we are willing to challenge clinicians too. That's our role, right? We are here to make sure that we're providing the best quality care and that we're helping those individuals who are providing the care to be the best that they can be. We want to help them grow. And we're going to do that by challenging, hey, what's going on? You know, what techniques are you using? How are you coming at this? And checking in on, has there been a drift here? Have we kind of lost focus on what this person came here to gain? And of course, it goes without saying, but we'll say it anyway, that this is always individually based, very person-centered. So even though we're talking about episodic care, we're not looking at rigid formularies. Each person who comes in, we are going to ensure that we're looking at them as an individual. And so when you come to kind of that 8 to 12 sessions, it's not just, oh, well, you know what, we do episodic care here, so you're done. No, if someone is really needing something a little bit different, say there's extensive trauma history going on, you know, something else has popped up that legitimately requires, hey, you know what, we need to add a few sessions, bring that to supervision, identify, all right, what are we going to be doing to, you know, extend this, and for what length? Because when we do make those exceptions, we want to make sure that we're not just then letting that drift off, you know, kind of going on for an indeterminate amount of time. What is that going to look like? What's our new goal? And of course, extremely important that we are making sure every individual who comes into our office understands what the framework is going to look like. Most of us who work in community organizations are familiar with CARF or with JACO, and we are all expected, or you know, with Medicaid too, we're all expected to begin discharge planning from the moment someone walks in the door. But how much do we really do that? And how unfair is it to the individuals that we serve if we really aren't doing that successfully from the beginning? Sort of sets people up to have a struggle when they go to discharge. And so it's really important that we actually start that process. We're very transparent and we talk them through what they can expect, kind of timeframes, et cetera, as we go. So that's really, really critical there as well. Next slide, please. So what do we do about those difficult to transition clients? You know, you all, I'm sure when I just asked that question, somebody's popped into your mind right now. If you've been in the field for a little bit, maybe a few somebodies, this is always going to be the case that you have people for whom transition is scary. I mean, for many of us, going through major changes in life is very scary. That's absolutely normal, part of the process. You may even have people who say that they're going to self-sabotage in order to remain in care. Sometimes that is something that people will just outright tell us, right? Well, if you discharge me, then I will X, right? And they're kind of letting us know that, hey, you're not going to be allowed to discharge me. I'm going to make that challenging for you. So should somebody get to that point, they are trying to self-sabotage in that case, well, for whom it's just, you know, a very scary moment, we want to just make sure that we're using that, right? We're using it in therapy, and hopefully, because we are doing our due diligence to help people through this process, we're not coming to them with this at, you know, session, I don't know, 11 of 12, that they know that this is coming. We're preparing for discharge maybe at session 8 of 12. So you have time then to sort of process this. What does this mean for them? What is making this challenging for them? Always important, of course, to remember how somebody reacts in therapy is very often mimicking how they're reacting or their interactions with other people outside of therapy, and that can be incredibly useful for you too. And those reactionary responses also very often are methods that may have worked outside of therapy to get a desired result, which is very similar to bullet 2, but how has this impacted the rest of their relationships? And so this really is a helpful piece for you when you are getting ready to help somebody towards discharge. How are they reacting to it? And how might this be reflective of what's going on in their life too? So let's review some techniques. Go ahead and change that slide. So I like to say we can smooth the move for people. So there's multiple different suggestions and ideas, and of course you're going to have several others hopefully that you will have of your own, or that you can kind of problem solve with your supervisors or your coworkers. But of course, number one, and we know this as therapists, we want to acknowledge any fear and anxiety. We want to process that, we want to validate it, because it absolutely is very logical, it makes sense. And I think the normalizing process of that for people can be very helpful. Yes, absolutely. This is a challenging time. This is a nerve-wracking time. You know, we go through these types of experiences in our lives. Let's figure out how we can successfully do it here, so that when you come across additional challenges and changes in life outside of here, you can reflect back on how you successfully moved on from therapy and use some of these same techniques. So DBT, even if you are not utilizing DBT in your full therapeutic sessions, that's not the framework you're coming from in general with somebody, there are incredible tools that you can utilize for someone who, and I put in quotes, who is acting out, right? So if somebody is talking about self-sabotage, somebody who, you know, is kind of identifying that this is kind of a crisis situation for them, there's really great tools that you can use there. The link that I have here from Skyland Trail has an incredible breakdown of many of those basic DBT tools that you can utilize that I would strongly recommend using for those individuals who do go to that extreme when we're looking to transition them. It really breaks it out for you, you know, the STOP method, some of the other things that they have there for DBT, distress tolerance tools, really, really helpful. Of course, we also, as we acknowledge the fear and all of those elements, we can focus on the fact that they're in control of this process. So, you know, yes, this is something that we're doing and we are working towards this, but you do have a choice here. And that choice is, are we moving towards this successful resolution? Are we doing it together? Are we going to remain stuck in this fear and not make that progress? That's up to you. I'm here either way, you know, and this is what we're moving towards. But I'd love it if we could do it in this way together. So can we do that, or would you rather do it this other way? So providing those little bits of options. One thing that I really think is so helpful, particularly for people who maybe have been in the therapy for a very long time because it's comfortable, it's filling a void in their life, identifying how they can continue to hold that space in a way that's helpful for them, that meets the need essentially that you've been needing as a therapist to fill that space. So what is it that they really benefited from in coming to you after their goals had been met, et cetera? Was it the routine? Is it just the comfort of having somebody who will listen to them? Was it just being able to get out of the house somewhere? You know, what is it that they really got from that? And then we have that conversation, and I've sort of put in a little bit of a way to start that. Let's hold the same space or time while you adjust to the transition for something still focused on you. Can you establish a regular coffee date at this same day and time? Can you, you know, schedule time for yourself to read a book, join a counseling group, right? It doesn't have to be completely out of counseling. Join a meetup group for some activity or hobby you've been interested in. What can you do to still hold a special place for this time that's going to help them make this a little bit easier? And then as you do that, you're also increasing lengths of time between sessions. So, brief CBT does this intentionally between those active and booster sessions. But I think that's a great tool to be utilizing in general if you're not already using it, and even if you're not using brief CBT, because it's going to help people gain that time to adjust to not seeing you every week or every 2 weeks or however often it was. And that's also where you can be putting in that, okay, next week we're not going to see each other, maybe we're moving to twice a month, maybe we're moving to once a month. Let's try out this coffee date, for example, that you're going to do on Thursdays at 1 p.m. when we would have met, and the next time you come back together for that next session, you're talking about how did that go? Is it filling that need that you had? Where can we make adjustments to make sure that that's working better for you? And it's going to help them kind of adjust to it. It's going to give you the opportunity to help them make that adjustment, and they'll see that you're here to do it together. In addition, and this sounds so simple, but I cannot tell you how many times I've seen just this reframe, this shift in thinking make a huge difference to people who are really, really struggling with a transition. And that's reframing it from discharge. I think discharge for many people is a dirty word, right? A lot of people see it as you're abandoning me. And so as much as for us, it doesn't mean anything negative, generally speaking, for them, sometimes it can for certain people. So sometimes I like to reframe it as graduation. It's a successful move into the next chapter. So instead of talking about, hey, we're going to plan for discharge from the very beginning, we're going to plan for your successful move from the very beginning. We're going to plan for the moment you graduate from this, and sort of setting that expectation at the beginning that therapy is not meant to be in this situation something that you're staying in forever, kind of as that protective element. It's something you can always come back to, right? It's something, another challenge comes back up. Hey, let's come back in. As Dr. West had mentioned earlier, let's adjust that dose, right? But we're not going to maintain a dose of something ongoing with no end date in sight if it doesn't make sense. So we can talk to them about it as graduation, successfully moving into that next chapter, which can really make a huge difference. And of course, as Dr. West had mentioned, motivational interviewing techniques, rolling with that resistance for people who are struggling with it, is an incredibly useful tool. I think we all know that. There's lots of training that we can do on motivational interviewing, but it's that element where, particularly when we're looking at people who are struggling with the idea of making that next change. So maybe they've been successful in meeting their goals, but they're a little pre-contemplative about leaving therapy, right? So stepping into that next phase, we ask them, what is it that they're benefiting from continuing this behavior, this activity, whatever it might be? So how does staying in therapy with no end date really get you what you want, right? So we can go back to what it was they really wanted. Hey, I wanted autonomy, I wanted more successful relationships, etc. So how does just staying here really get you to that, and working with them processing that? And then ultimately, we want to talk about, can we implement as an organization or as a clinician, step down and aftercare groups as an option? Sometimes for people this can be really helpful. So let's look at what some of those barriers and solutions are. Go ahead and change that slide. So what I often hear from clients or consumers and from clinicians are several of kind of a predictable list of barriers, the red flags, so to speak. So what I hear from our consumers, from our clients, hey, I don't want to share in front of other people. I'm very uncomfortable, I'm embarrassed. There's concerns that I have for my privacy. I don't want anyone else knowing what's going on with me. And very often we hear people talking about that fear of appearing weak for needing help, again, because other people are going to be aware. And I put others with a question mark on there just to kind of look in at your own client base if groups are something you are interested in establishing and haven't yet. What else are you hearing? Because the more you understand about what is causing people to kind of have that fear or hesitation, the better you're going to be able to approach it. And then from clinicians, very, very often what I hear is, well, we would love to do groups, but when we talk to the clinicians, no one really has experience with it, and everyone's kind of nervous about starting to do groups. And I find this very interesting. I know where I did my training, it was required that we co-facilitate a group before we could graduate, and I thought that was very valuable. But I recognize that's not always the case. What I think is interesting is so many clinicians have not had the opportunity to do groups, and yet very often when people do start doing them, what I hear is, man, I really love doing groups. I know a lot of clinicians who prefer groups once they start doing them to individual sessions sometimes. So when people say, well, I don't have experience doing it, I kind of like to look at that as a, wow, what a great opportunity for you to check this thing out, see how you feel about it. But that comes up a lot, lack of experience, or we're just not sure how we would structure it. We don't know how it would work in, we don't know how the billing would work, etc. And then how do you market it? Because if you didn't already have it, how do you get people to come? So those are some of the barriers that come up. And again, I've put others in there because if this is something you're interested in, bring it back to your team and talk about it. What's preventing us from doing it? What are the other barriers that you're experiencing? Next slide, please. And so what are the solutions? Some of the common solutions that are helpful, again, reframing the move to groups. So for a lot of people, we talked about what their concerns and barriers are. Graduation, that term can be very, very helpful. You're graduating, you're moving on, you're successfully leveling up basically to a new level. For many people, it's also helpful to hear, particularly if you come from an area where part of the main value of that area is, you know, hey, we help each other, right? If Bob down the street needs help with something, I'm going to help him out. I go help him, or Jane over here at the store, whatever. If they need help, we come to their aid. And so identifying what it is about the area, the person that can help kind of reframe it for them, because it could be helping others by sharing your knowledge and experience, and conversely, an opportunity to learn skills and ideas from a broader group. I think very often when people hear, hey, you know, you have the opportunity to discuss with other people who've been through what you're going through in a way that is different and equally as valuable as what I can share with you as a therapist, sometimes that can be helpful. You know, just give it a try once or twice. And then with clinicians, some of the solutions to those barriers, you know, look at whether co-facilitating is an option for new group leaders. Is there someone who has more comfort that will allow another clinician to come in with them for their first groups? Spend time ahead of time structuring the topic. You want to make sure you know what it is that you're doing, so that helps improve your confidence. And then when it comes to marketing and having your groups be successful in the long term, for me personally, it's helpful to keep those groups open. So not closed groups if possible, depends on the topic of the group, of course, and just allowing people to step down into the service from your program who are discharging, but also to enter services for the first time. So brand new people to the organization as well. And then marketing that to the community, putting out a flyer, sending that to your partners, putting it out in areas where the individuals that you think might benefit are hanging out already. Next slide, please. When I work with organizations with MTM specifically on helping them get this set up, one of the things they say is we just really don't know how to decide on what groups to do. So my suggestions for you here are look at the area that you're in and the present need of the population, right? Looking at it from a here and now kind of perspective, because how you determine what groups are necessary might change depending on the time, the space, etc. Very valuable, take some time to survey your existing and new clients related to topics that they might be interested in as people come in, as people are leaving, as you have them in therapy. Hey, you know, if you were to participate in a group, what would you like to see? This is a good opportunity for clinicians to identify if there are special interests that they'd like to explore. This gives them the chance to sort of work on that. And then these are just some examples of some of the groups that I've seen different areas sort of take on where they've identified that this works for them. And notice that the last one, keep it moving, that's something that can be very helpful as an aftercare group. How do we keep moving forward, focusing on coping skills? Next slide. And finally, remember, we need to be able to explain why. So for everybody that we're working with, why is it that this is important? Why is it that we're working on episodic care? What is it that we're really meaning to gain here? So when you're moving from long-term treatment to episodic care, there's of course going to be pushback, challenges, and difficulties. However, What I like to remind everyone is, as your caseload refreshes, and just you set expectations from the beginning, as you clearly go through that, it's going to get smoother and easier. You're going to make the topic of medical necessity much easier to demonstrate. And most importantly, the individuals you're serving are going to receive the focused and guided treatment process that they deserve. And I'm going to go ahead and hand that back over to Dr. Westhead to wrap us up.
So hopefully this has stirred some creative juices with all of you as to how you might incorporate some of this into your service delivery. I think some closing notes that I thought of, especially as Katherine was talking, is that, you know, change requires an urgency. We need to be able to help clients understand there's a timeline for this, because not changing is holding you back. So we're going to set a timeline that is a reasonable timeline to achieve your goal, so that the urgency for the need to change is very clear. I think another thing that came up as she was talking was multidisciplinary team is important for supervision as well. Working collaboratively across the aisle between disciplines is another important part of supervision. Katherine and I have been involved in routine, multidisciplinary treatment team meetings where we're all throwing ideas on the table, especially for those harder cases. How do we work through how it can be worked through on medical and clinical case management, et cetera. And finally, I think one of the things that episodic care does is it gets us focused on establishing, as I said earlier, the individual's resilience and self-reliance. They come to depend on us, and we need to make sure we are putting that back on them so that they can understand that they can depend on themselves. So again, medical necessity, stratification of services, the effectiveness of these models, and then how to start to put them in practice, starting to make change that is meaningful for your clients and ultimately for you. So we have a moment if anybody would like to unmute and ask a question. Katherine and I would be more than happy to answer. So please feel free to open up your mic and let us know if you'd like to ask us something. Well, I know we are at the end of the hour and everyone has other things to move on to. Thank you for joining us for this webinar. This recording will be up and available at the MTM website in a few days, and the slides, you can access them through that recording. So thank you again for your time, and we look forward to hearing back from you as to how you've made some changes that you're excited and happy about. Have a great day. Bye.